possible they've got a renal calculus that is causing their trouble. Right, so let's go down, 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 follow that ureter, follow that ureter, follow that ureter. And actually, it doesn't look like there's any calculus located within the region of the ureter either. So we've got to go back to square one, I guess, and try and figure out what's causing this person's trouble in the first place. So let's go from the bottom here, coming upwards, 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 upwards. And the thing about the sigmoid colon, it can be very, very mobile, right? So following it up, coming up to around here, we'll come all the way up down to here, is it? Feels like it's coming back down. Just about this way. Yeah, look, here we go. So there it is. So it did come back down. So it went all the way back, all the way up here, then all the way down like so, and then became the sigmoid colon again, and then turned back on itself, and then became the descending colon. And it's in this region over here. Can you see? It looks very, very inflamed. And so they do have some diverticular. You can see a few diverticular sitting over here. So this looks like it's going to be diverticulitis. So one of the important negative findings for a diverticulitis is there perforation or is there a collection? So this doesn't look like there's a perforation. It doesn't look like there's a collection. I haven't seen the free air anywhere in this initial look. But now we've got to go to the lung windows and have a good look around here as well and try and see whether there's any locules of air located anywhere within the vicinity. So it doesn't look like there's any locules there within the vicinity. So go away and say, you know what, I think we're okay. This person hasn't had a perforation at all. But now when you come up to the upper images again, you may even spot it when you're doing your lung, you're having a look at the lung images, is that there is some radiolucency over here and here. So that's lung, that's diaphragm, that's air. And that is air is sitting all the way up in the upper abdomen. And coming further down, you can see more locules of air located over here. And now you kind of spotted one, you spot like a whole load of locules of air all over the place in the upper abdomen. And so the only pathology you really have is that diverticulitis, right? But then all the air is located within the upper abdomen. So have they had a perforation or is there another perforation? Could there be a duodenal ulcer that's kind of come up here? The duodenum is actually completely normal in this study. And what actually happened is this person had diverticulitis and they basically sat at home with it for as long as they could. And then they perforated and sat at home with it for as long as they could. And then it sort of self-sealed itself. But that air that did escape ended up sort of coming up to the upper abdomen. And so they're trying to walk around and doing maybe even sitting up with the pain that they had. And all the air kind of ended up coming up to the upper abdomen. So I think this is a really good case because it feels like it's just going to be a normal case of diverticulitis, no perforation, no collection. But again, by doing your checking of doing the lung windows and the rest of it, you start to notice that there is some extensive amount of free air. So the person did have an extensive perforation, and it's possible that they've ended up sort of auto-sealing itself over time because they basically avoided coming to hospital for as long as they could. So this case is another trauma case, and this is someone that ended up being in a car crash. They were the passenger, and it was a quite significant speed. So let's have a look through. So this is a trauma study. Going through, we haven't seen anything grossly abnormal on the first instance, but now, yeah, there is what looks like some material that is located within the upper abdomen, adjacent to the liver, causing some scalloping. So it's actually pushing inwards. So maybe sort of slightly hyperdense fluid. So it feels like they probably had a significant liver injury. I haven't seen it go across to any of the vessels like we saw with the other case. So therefore, there's going to be sort of a lower grade, sort of a subcapsular injury with a subcapsular hematoma causing that indentation. Right. Because you've got quite a significant injury over here, we've got to look and make sure there's no other injuries anywhere else. The kidneys are very, very bright. They don't look like they're particularly abnormal. Ideally, I'd actually probably window the kidneys to be a little bit less bright so I can have a closer look and see what's going on with the actual parenchyma there. So that actually, they look okay. Doesn't look like there's any lacerations there either. But you can see their spleen looks normal as well. Now let's come further down into the pelvis. Coming further down, there looks like there's a lot going on with that pelvis, a lot going on within this region over here. It doesn't look quite right. Coming further down into the pelvis, the rest of the bowel looks okay, but I'm not quite happy with that right iliac region there. So the thing I would do is just to go through the bowel, just follow along and see if you can see anything grossly abnormal with the bowel. You can see we're coming up to this area over here, which is going to be the descending colon. And generally, this bowel looks very, very unhappy. Looks like it's thick-walled. There's some linear density adjacent to it as well. Looks like there could be some fluid located within the paracolic gutter. Coming up to the transverse colon, Transverse colon looks okay. Coming down to the iliac fossa again, this does not look right. It looks like there's something going on. So we're going to zoom in a little bit more and try and see what's happening. Zooming in, you can see that actually, you know what? There looks like there's a defect on that side of the abdominal wall. So abdominal wall, and there's some sort of like extrusion of material located within the area emanating from what looks like could be the cecal pole. And just generally, the cecal pole doesn't look very happy and looks like bowel, and then looks kind of discontinuous located within that sort of lower abdominal area. So it looks like what we have here is a herniation of some of the intra-abdominal fluid through a defect in the right abdomen. So this is not great. And then actually looking at some of the bowel, so this is the bowel over here. Can you see that? It doesn't look like it's enhancing particularly well, but the rest of the bowel is sort of hyper-enhancing. So look, lack of bowel enhancement over here as well. Some of this bowel does not look happy. So we've got what looks like potentially a perforation. You've got a herniation of some of this fluid from inside the abdomen, and it looks like you've got significant bowel injury, which has resulted in ischemia of the bowel as well. So if we're thinking there could be a defect within the bowel, we should try and make sure that there are no lockuses of free air. And actually, yeah, look, free air all over this area over here. So there is definitely a bowel perforation there. So what it looks like, we've got a few findings here that has happened with this person. This person has had a significant hepatic injury with a subcapsular hematoma, and we've got some intra-abdominal free fluid and potential hematoma. We've got some ischemic bowel, which looks like a small bowel, particularly within the region of the pelvis. We have got a perforation of what appears to be the cecal pole and some herniation of intra-abdominal contents through a defect in the right abdominal wall. And the whole reason this has happened is because they were wearing their seatbelt. They were actually being safe and they've got a seatbelt on. And actually, when you look at the sort of subcutaneous tissues over here, if we look at this area, you can see sort of linear fat stranding within the subcutaneous tissues going all the way across like so, and then all the way down here as well. And so what's happened here is that it was such a significant deceleration injury, the seatbelts got tight, it's tried to hold them in, and it's increased the intra-abdominal pressure and resulted in these quite significant injuries and the hernia coming through the side of the abdomen. So this is all not great news, is it, for this person? So the next thing to do is to check the bone windows. So let's go for the bone windows, starting from the very, very top. We will do the sagittals and the axial views in a second, but one of the things that you may spot is that they do have what looks like a fracture of the radius and ulna. So sometimes what used to happen is that when the trauma patient came in, the team would say, look, we're worried they've got a fracture of the humerus or whatever. Can we include that? And normally you can, you just put the arm across and you've got it there. But you can see there's a significant fracture there. But what we're really interested in is that when you've got such a significant acceleration, deceleration injury, right, you've got the seatbelt and the person flies forwards, it's holding you back, but that's not necessarily a good thing. And you can end up getting something called a chance fracture. So very, very important, have a look at the actual lumbar spine and have a look and see whether there's any area that could be abnormal. And there's this area here that does not look normal at all. So let's go across to the sagittal views. Sagittal views, yeah, you can see that there is what looks like a significant injury of what looks like the L3 vertebra. Yeah, there's some retrolysis, some loss of anterior vertebral height. There's some widening of this fracture located that goes through the pedicle, through into the spinous process. And then on the other side as well, quite an extensive fracture that's opened up as well. So this is a really, really significant injury. Wouldn't be surprised if there's going to be quite an extensive hematoma located within the spinal canal, resulting in some level of spinal canal stenosis. There's a lot going on this one. And I think that, again, satisfaction of search can be really, really important, and sort of not understanding that the mechanism of injury that can really affect your interpretation of the images, right? Because here we had someone that's clearly had a significant amount of intra-abdominal pressure as a result of the acceleration deceleration injury, which has resulted in a myriad of findings on this person. So this is another CT-KUB, and this one was looking for left iliac fossa pain. We scroll from the top and we can see that, yep, this person's having a CT-KUB. The table is sitting over here and they are lying on their front. We're looking down that sort of left iliac fossa, so left iliac region, or the left side of the body. That kidney looks like it's okay, doesn't look like it's blocked off, and looking at that ureter going all the way down, looks very, very thin. Let's come up to the other side, just make sure that, you know, sometimes you get your lefts and rights wrong. let's have a look, and we can see, yeah, that looks okay. Doesn't look like there's anything grossly abnormal. And then as you come further down, further down, further down, further down, further down into the pelvis, there's no stone there. So no stone to be found, no stone unturned. Now let's have a look at the rectum coming up here. We're going to just follow up just to make sure there's nothing abnormal, no diverticulitis or perforations or anything like that, like we had recently. That looks like it goes across that way. Looks like this goes across this way. This goes all the way up. So there's the descending colon. That looks okay. Hepatic flexure looks okay. Coming across the front is going to be the transverse colon. Transverse colon looks good. And then the ascending colon looks good. And then there you can see the appendix that is sitting over here. So we could say, yeah, we haven't seen anything grossly abnormal. But some of you may have spotted that there is something that's clearly sitting over here. Can you see that? So let's zoom in and just have a look and see what's happening. Yeah, there looks like this spherical weird lesion that's sitting over there, but quite in the mid-abdomen, the mid-pelvis, right? So what could be causing that? Let's follow this up again. Sigmoid colon, sigmoid colon. And actually, it's quite near the sigmoid colon, right? And it's on the anti-mesenteric side. Now, we've already seen, like, yeah, sigmoid colon can be very, very mobile. And so this sigmoid colon loops up in the middle of the abdomen and comes back down again. And so on the anti-mesenteric side, what we have here is a very hyperdense rim-like structure, and you've got someone who's got this sort of abdominal pain. Now, sometimes you actually see a very hyperdense dot within the middle of it, which would be therefore be indicative of a thrombus. I don't think we can see a thrombus on this one, but this would therefore be overall in keeping with epiploic appendigitis rather than a renal stone causing this patient's problem. Again, these kind of things, satisfaction of search. You've got someone who's got a CTKB, you haven't found a stone, you haven't seen any diverticulitis, no appendicitis, you think you could just move on. But actually, yeah, you know, having these check areas, having that kind of idea in your head that, okay, left iliac fossa pain can also be epiploic appendicitis, can just be enough information for you to actually look further and try and look for the epiploic appendicitis when it's there. Okay, so to finish this talk off, I have got a bit of a mammoth case. I hope you guys don't mind it, but it was one that kept me up for quite a while and kept me thinking. And these kind of cases you don't really want to have at 3 o'clock in the morning. But anyway, this patient has had previous surgery, extensive bowel surgery, and now coming in with dropping HB and significant abdominal pain. We've got the arterial images here, and let's have a scroll through and just see what we think. So having a scroll through, it looks like there's quite a significant amount of fluid located within the region of the pelvis. Okay, fine. There's a lot of fluid within the pelvis, and this line over here feels like it could be some sort of artifact. But actually, this is hyperdense fluid and a slightly more hypodense fluid. So there's actually layering of fluid located within that pelvis. So this is abnormal. This therefore must be a significant hematoma, and there's sort of organization of the hematoma as time has gone on. And you've got the more dense stuff at the bottom and the less dense stuff at the top. And as you come further up, as you start to realize that none of this is actually going to be artifact, yeah, this hematoma extends towards the right over here and all the way to the top. So at first you may have thought that this could be bowel. This over here is not bowel. And so we've got a significant amount of intra-abdominal hematoma that's come up to the very, very top. Can we see where this is coming from? We can see that, yeah, there's again some scalloping of the liver. So it could be a potential liver laceration. It could be. But it could also be extracapsular, and it could be causing some mass effect as a result of it being hyperdense material. Right. But now when you look at the bowel, you notice that, yeah, there are some loops of bowel that are here, which look very hard to distinguish. This looks like some small bowel. You can't see much in the way of valvular convergentes at all. And this is small bowel here. But look at the bowel that's over here. It looks very, very hypo. Looks like it's hypo enhancing. It looks very, very abnormal indeed. So now you're going to start worrying about the possible potential that this person's also got ischemic bowel on top of the problem. So far, finding number one, large hematoma located within the pelvis with some layering and also some scalloping, and it extends towards the right upper abdomen, causing scalloping onto the liver. And now it also looks like there's some ischemic bowel located within the lower abdomen and within the left abdomen as well. Okay, so this is clearly an emergency. We've got to let the clinical team know. But actually, if you look at the IVC, it looks like it's very, very flattened, almost pancake-like. So they have bled so much that they're actually looking like they could be hypovolemic. And actually, the ischemia could have happened because of the hypovolemia. Yeah, I mean, that's all within the realms of possibility. And there's quite a nice narrative for what we're seeing so far. Right, next thing is, NG tubes. They've got an NG tube and it stops right at the gastroesophageal junction as well. So you probably don't want to be using that. That may actually result in potential aspiration later on. So we need to let the clinical team know about that too. Now let's have a look at the rest of the upper abdominal structures. And actually you notice that that kidney there compared to that kidney there, it looks slightly dusky in enhancement, and it looks like there could be some hydroureter going further down, further down, further down. It looks like it's quite dilated all the way down, all the way down. And it's probably because of the large pelvic hematoma causing mass effect, causing renal tract obstruction as well. And so now we've got someone that's got quite a significant bleed, got quite a significant intra-abdominal hematoma. We found all the findings with regards to the hypovolemia. We found the large hematoma. We found some renal tract obstruction and secondary ischemia, but we haven't found a bleeding point. So bleeding point in this arterial image, you've got arterial blood located here, and you've got to try and see whether there's anything that's of that density located anywhere else in the abdomen or pelvis at all. And actually here, can you see that there is this hyperdensity that is located at what looks like could be bowel, and follow that along, it doesn't look like it's bowel. Following that along, it doesn't look like it's bowel, and actually the bowel is sitting over here. So you've got this solitary area over here which has got hyperdense material, and it almost looks like it's layering there as well. So you've got a focal bleeding point there. This person is clearly bleeding from an active bleeding point located within the right mid-abdomen, and there's an extensive hematoma that is going through into the imaged pelvis and into the right upper abdomen as well, causing some scalloping of the adjacent liver. There's also secondary bowel ischemia, and there's also flattening of the IVC secondary to hypovolemia. The mass effect from the pelvic hematoma is causing a right-sided renal tract obstruction and subsequent dusky enhancement of the right kidney. And on top of that, you've got a misplaced NG tube, which would benefit from being resited or advanced further. Right, we have been through quite a few cases, and I really hope that that's been useful. At the very least, I've given you entertainment, because those of you that do radiology, enjoy radiology, or are interested in radiology, may enjoy just going through cases. I mean, going through cases is good fun. Also, it may give you a few check areas, a few things to think about when you are going through your imaging and going through your own practice. I would highly recommend doing the MIPS on the MPRs, using the MPRs, and definitely checking every single window that you can. And lung windows aren't just looking for lungs, you know, they can pick up some really interesting findings. And over the years, it's got me out of a few difficult situations. So anyway, thank you, Everlight, so much for having me. I really appreciate it. And if you do want to find me, you can find me on my website, imranlaskar.com, find me on Twitter, YouTube, all those kind of channels. I do like teaching, so do give feedback. Do let me know whether I did well or not. And if there are things that I could improve, I would really appreciate it. So until next time, stay well, stay out of trouble, and try and stay safe. Yeah, try and stay out of the A&E room. All right, bye.